Good morning to everyone, and thank you. Thank you to Julie and to the leadership and the participants in MARF, and especially to those of you attending the conference in today's session. So I'm here to talk to you about the diagnosis of pleural mesothelioma. And to cut it short, diagnosis requires biopsy, and that's why this talk is about biopsy. As we surgeons like to say, tissue is the issue, and we'll see if the pathologists agree, but I suspect based on these pictures alone that that is the case. Just trying to figure out. There's the pointer. So diagnosis requires biopsy because biopsy is what distinguishes cancer from non-cancer. And patients often ask me if the imaging, as just discussed by Dr. Strauss, why isn't that enough to tell whether I have cancer or not? And it's just plain not. There are too many things that masquerade. Importantly, in pleural mesothelioma, we need to distinguish a primary cancer of the pleura. That's what pleural mesothelioma is, from cancers that spread from other organs to the pleura, which is actually stage 4 or metastatic cancer. And that's one of the challenges to our pathologists, but requires tissue. Tissue and biopsy are also required to figure out the cell type, epithelioid versus sarcomatoid versus biphasic, and some rarer entities. They behave differently, they respond differently to treatment, and it's important for individualizing care. And as testing becomes more sophisticated, biomarkers and next generation sequencing and protein and genetic expression are all becoming relevant for treatment and patients, and are helping patients survive longer, which is the ultimate goal. So your perspective on how to biopsy or what to biopsy sort of depends on who you are. The radiologist might say something different than the surgeon, might say something different than the pathologist. But really the one that matters most is the patient. And if I were the patient, I would want the biopsy that is most likely to yield an answer and be most likely to be successful with the least risk. And I generally think about that in terms of invasiveness. So from least invasive to most invasive, the biopsies can be of the pleural fluid. So often patients will come in with a pleural effusion or fluid between the chest, the rib cage, and the lung itself. And some information may be obtained from that fluid, or a needle biopsy of the tumor, or an incisional biopsy. And so we'll talk about those. So the pleural fluid, this is actually a Wikipedia diagram that I thought was pretty good. There's amazing what you can learn. The chest wall and the lung, that space in between is the pleural space. And in healthy patients, that is a non-existent space. But if fluid or anything else accumulates in there, that becomes a pleural space. And when that's fluid, it's called a pleural effusion. And that can get analyzed. A lot of times our pleural mesothelioma patients present with a recurrent pleural effusion. And many people might have that story where it's been drained and analyzed. Unfortunately, about 60% of the time, it'll come back benign, even if there's cancer. And so the sensitivity or the likelihood that the test will show cancer if someone has cancer is pretty low. And so then there's the needle biopsy. That's a little more invasive. That's actually biopsying the tissue. And pleural mesothelioma is a pleural-based disease, which is generally the outside, as we saw in Dr. Strauss's pictures, the sort of outside of the lung and very close to the skin. It lends itself to a percutaneous or skin-accessed biopsy, image-guided, ultrasound or CAT scan, and that can be done with a tiny needle and a little few cells aspirated, called a fine needle aspirate, and that gives cytology, which is similar. It has some limitations in what that can show, or a slightly bigger needle, but still done under local, even without sedation, can give tissue. And kind of old school teaching was that the architecture of kind of the tissue itself is actually important for a lot of cancers. And in fact, this is one of my patients who has the patient's on his belly. And so this is the left side of the chest, and this is an area of nodularity that was suspicious for mesothelioma, and it was accessed by the radiologist under some local here. This was not painful for this patient. The nice thing about and then we got surgical pathology, we got actual tissue from that. He was actually enrolled in a clinical trial of mine in which we analyzed that tissue, and then we used that same needle to inject poly-ICLC. It's a protein-based vaccine that we're finding stimulates the immune system. So patients 2 to 4 weeks before surgery underwent biopsy and then injection of this vaccine. We enrolled and closed accrual with 19 patients, which completed the study. It was safe. Some of them had fever for about 24 hours, but short of that, very few symptoms. And what we're finding now that we have analyzed some of the earlier patients from 4 years ago is that this seemed to turn the tumors on. So we're looking at this in the lab, and it has converted the tumor microenvironment to a more immune active environment, and they seem to be more responsive to additional therapies down the line. Then we come to this sort of most invasive form of biopsy, and that's an incisional biopsy. So these can be small incisions, but that's required and gets larger samples of tissue, which by definition, by sampling alone, are more likely to give you an answer. And surgically, we consider fluoroscopy a procedure with a tiny incision that we can actually stick a mediastinoscope, which is this rigid scope through, and you directly access the extrapleural space where that tissue is and can get samples and an answer that way. Many times patients undergo VATS. VATS is video-assisted thoracic surgery, and that's keyhole surgery. I usually do it through one small incision. And I do that, it can be done under sedation. If the patient tolerates general anesthesia, it's a little more comfortable. It can be done on medical thoracoscopy is sort of the term that the interventional pulmonologists use, where they stick a little scope in the pleura, but it's really the same concept. And I usually reserve that for patients who I'm unsure what this pleural process is, and mesothelioma is in the differential, but it could also represent infection, or it could represent another cancer, and I want to get some samples. If I see tumor, that obviously that's what we sample. If sometimes patients have a sort of irritated pleural process that's suspicious possibly for mesothelioma, and you want to get some random samples. And the nice thing about VATS is you can explore the entire chest through that. Now, thoracotomy is the most invasive thing that can be done, and sometimes they are done diagnostically. Sometimes we term it an exploratory thoracotomy. Usually for pleural mesothelioma patients, that would be in the setting of someone who came in with what was thought to be an infection. And this story, and it may have happened to some of you, is where somebody has a cough and some shortness of breath, is thought to maybe have pneumonia, and they have a pleural effusion, and it's thought that this was a complication of pneumonia, something called a peripneumonic effusion or an empyema, and they ultimately find their way to a surgeon who would try to sort of peel the rind and process off the lung to try to expand it or decorticate the lung, and the pathology shows that this is actually cancer, and it wasn't really infection to begin with. But this does happen. It does provide a lot of tissue, but it is by far the most invasive thing that can be done to make a diagnosis. I put this in the category of other. So bronchoscopy is not usually useful for the diagnosis of mesothelioma because the airway is the most central portion and the furthest away from where this pleural process happens. But sometimes if a patient has some airway issue that needs to be evaluated, or in particular if tuberculosis or some infection is thought to be the etiology, this is how that diagnosis is made. Usually, so a scope is put in through the trachea and can evaluate the airway. Endobronchial ultrasound, that scope has an ultrasound on it and can see next to the trachea, and that's really more useful for a lymph node assessment. We'll talk about that in a second. More sophisticated tests are coming down the line and are being used, especially for patients whose tumors have some signal in their blood. We call it liquid biopsy. There's circulating tumor cell DNA, there's cell-free DNA. There are other biomarkers that are relevant, especially in certain patient populations. That's not routinely used, but is becoming more and more useful. So just a quick word on staging, because biopsies are relevant to that as well. Staging is very important. The sort of workhorse of staging at this point is clinical staging through a PET CT, as Dr. Strauss had discussed, and that is helpful, but again, has some issues of sensitivity and specificity, meaning not everything that lights up is cancer. Someone brought up the pleurodesis from 30 years ago that will light up and they may not represent cancer. And not all of the cancer lights up, unfortunately. So there is pathologic staging, meaning actual biopsies, and I think it's becoming less and less commonly done routinely. But where I trained, a mediastinoscopy or an incisional surgical biopsy was done to evaluate the lymph nodes in the center of the chest or the mediastinum. Now we have endobronchial ultrasound that can do that through that scope that I discussed before. And some centers still do staging laparoscopy for all patients with pleural mesothelioma. They assess the abdomen with a laparoscopy. I reserve that for patients who have evidence or suggestion of possibly having tumor in the abdomen. We want to distinguish it from an unrelated cancer or some other process. In particular, if I have patients with lymph nodes near the liver or the stomach or intestine, I might evaluate that with laparoscopy. But some people still do stick a scope in, wash around, and send that fluid for analysis. Diagnosing recurrence. In an ideal world, you would have tissue. And so if the tumor is accessible, it sort of depends on the risk and benefits of biopsy and whether it will affect the decision your treating doctor is making. So if having the tissue or not having the tissue doesn't affect the treatment that you're going to get, it may not be worth any risk. But if one course of treatment, if the tumor shows this, or one course of treatment if the tumor shows that, or whether it represents recurrent or progressive mesothelioma at all. For example, some behaviors are weird. I have had a patient who tumor was showing up in the muscles of his back, and it was kind of hard to believe it. Not in the space where he had surgery. It was, I think, in his leg, or someone had in the back, another person had the leg. We do see metastases, which is unusual. So confirming that is cancer and confirming that is mesothelioma is important. And sometimes for cell type or genomics, this is relevant. And again, the liquid biopsies are becoming more sophisticated and very helpful, in particular for patients who have some signal in their biomarkers in their blood. But the most important thing is still multidisciplinary treatment. Having a surgeon, a medical oncologist, a radiation oncologist is very helpful. We have a great team at the New York Mesothelioma Program. I'm very grateful to them. And in conclusion, you want to start for biopsies and diagnosing pleural mesothelioma. You start with the procedure that offers the highest likelihood of success with the lowest risk. This may include drainage of the pleural effusion, image-guided needle biopsy, or surgery. Tissue is the issue. Recurrence or progression might require biopsy, and multidisciplinary expert care really is paramount. And just thank you to all of you. I welcome any questions, and a quick shout out to my team at Mount Sinai.
Thank you, Dr. Wolf. We have time for one question. You have your hand up here first. I saw you.
How do you deal with a laparoscopy for a peritoneal recurrence when they have a lot of scar tissue, and they did one laparoscopy already before they knew the scar tissue, and they went into the small bowel, but so now they want to do another laparoscopy? How do you deal with that if you know that there are scar tissue in the?
So I'm a chest surgeon, so I don't have expertise. I do laparoscopy in the setting of pleural mesothelioma, but so I would defer to the surgical oncologist in the room. But I think it's an important question in general in the concept of risk and benefit, because a small bowel injury or an enterocontinuous fistula that might develop as a result is significant. And so that is an important point, but I would defer to the surgical oncologist in the group. I would definitely ask Jason or Travis.
Wonderful. Can we have another round of applause for Dr. Wolf?